paper. I don't have anything to
Dr.
write.
Hampton, I have no intention of telling you what you got yourself into.
Okay, I don't have a pen, so I don't need.
Oh, I will happily give you a pen for later. I
I don't have
promise.
a pen either.
Do you want to sit up here, or do you want to sit in the audience until 10 minutes? Sandy did yesterday. Neil was up here on. So whatever you prefer.
Sit up here so I can,
Hey, can we demo the other one? No?
Hap, I think we have. At some point, they're not going to be able to see anything going on at all.
Good. So that
You
means,
wanted less light?
so the three
Hap
of
is
us,
looking to
so
make
the
it
three of
as
us
dark
can
as
sneak
humanly
out and
possible.
never know it.
All right. I believe we are at go time. We are likely already streaming. Good morning, everybody, and welcome to day 3 of Pardon the Interruption. I am your host with very few skills other than hosting, Dave Schulman. We'll introduce our guests in a moment, but I appreciate your kind attendance. We are once again live streaming to our friends out in internet land. The internet tubes seem to be working at the moment, so good morning, everyone. I will ask the panel, be cognizant of the fact that we are live streaming, and please not do anything inappropriate that you would regret later. Although, Dr. Farber, knowing you very well, there's very little that you would regret later. Before we pardon the introduction, I'd like to go ahead and, pardon the interruption. Let's pardon the introductions, if we can. Here we go. First up, the devil from the city of angels, the guest with the most from the westernmost coast, hailing from Cedars-Sinai Medical Center. Ladies and gentlemen, I give you Dr. Vic. That's a load of Tapson.
Oh my God.
And that was his picture of choice, and we, of course, honor him with that.
Great looking audience, by the way. Great to see all of you. Brilliant, great looking audience.
If I could take a point away already, I would, but the game has not started yet. The audience will be able to grant points, but you can't suck up too early. Coming up next, the cardiologist with heart, the frantic romantic from the Mid-Atlantic, the un-PC MD from D.C., hailing from George Washington University School of Medicine. Doctor, you got to fight for your right to Marty Gomberg-Maitland. Please welcome Dr. Gomberg.
I just want to say that we all understand why I'm up here, and there's no other female up here.
I'm wondering if I should ask for clarification, but I probably do not want to ask for clarification of that. Well, I know who the man next to you is all too well. The crass doc who sits in Massachusetts, the beatdown of Beantown, hailing from Tufts University School of Medicine. Ladies and gentlemen, I give you Dr. Hap, a bridge to Farber. Hap, welcome to the octagon, as they say.
All right, so whatever.
That sounds about right.
Let's have at
I
it.
learned from him 30 years ago, and that's pretty much all I learned right there is whatever. So just rules of engagement for the audience. We have done this before, but for those of you who may have been maybe new to the Octagon, we're going to have about 14 topics listed. We're going to get to all of them that we can. For most topics, I'm going to select speakers in a random order. I will introduce my color commentator on the far end in just a moment. I'm going to ask my panelists to keep their comments under 1 minute. I will move on if I get bored. If you hear this sound, you've bored me. We're moving on. Volume, humor, and accuracy are encouraged in that order. I cut speakers off if need be, but more importantly, you should cut each other off if need be, because you will hear your opponents say silly things and you need to correct them. 4 points are available per topic per contestant, 2 for data, 2 for just being entertaining to the group. And I can take away points if somebody comes at you. You are welcome to come at me. I will warn you, Hap, since I was a fellow, I've gotten a little stronger and better at this game, so if you come at me, bring your A game. Audience, you have some panels. Hold up your panels or your pedal paddles for me if you've got one. If you don't have one, they're in the back of the room. Feel free to go grab one. If you hear something you like, feel free to give them a thumbs up. They can get points for that. If you hear something that sounds stupid, give them a thumbs down. They can lose points for that, so you are in charge. If you're interested in hearing more on a specific topic, I'm going to ask you to tweet at the hashtag ChestPTI. That's true for those of you out in the internet land as well. The gentleman to my far left, your far right, Dr. Victor Test. Round of applause for Victor Test real quick, please. Dr. Test hails from the Texas Tech University, and Victor will keep them honest with a little bit of a debrief at the end. So he is not an active participant, although, Victor, if you do hear something you want to hear more about, you are invited to jump in and poke the bear.
I will.
Thank you.
Marty has a comment that she would like to make.
Yeah.
Yes, ma'am.
Is that okay?
Of course.
If I interrupt. So, for those of you who have been around for a while, you know that my colleague here always has limericks that, outshine everybody. So I thought, I'm the youngest on the panel. I am the best looking.
Shit,
But-
that's too easy.
I know. But I thought I should come prepared so that, we set the stage. So here's a hippie PH doc named Hap, who's so old he needs his daily nap. A daredevil off-site, he skis and rides his bike. Does his coffee have added schnapps? Hap's dress at work is unsuitable. Confused with the riffraff is quite usual. Despite his looking gruff, he really knows his stuff. But thinking he'll win today is delusional.
Nice. All right, we'll give you one more verse, just in the interest
No,
of
I got
time.
two, right?
Okay, let's beat it along.
Here's the famous PhD Vic. In his day, he was a top-notch slick. He'll fool you with charm, thinking he'll do no harm. Look in his eyes, you'll see his true shtick. Vic is now working for the dark side after years as a star doc bedside. He's focused on clots, PH skills gone for naught. And then,
Lose he will, says Yoda, but
Wow.
he tried.
I will say Dr. Gomberg has done her homework. Round of applause.
Marty came
Unfortunately, she did not remember that until the game starts, you cannot gain points for
That's
any of
okay.
that.
That's
So
okay.
that's good.
Setting
No, I will
stage.
to give a minus points to the audience. You do not boo me here. That's never going to work. All right. So, folks, again, if you want to chat at us, Dr. Chess will keep an eye on the Twitters, and we'll come back later, but that's the hashtag ChessPTI for you out in the real world as well. Here are the first 8 topics. Ladies and gentlemen, it's go time. First topic, echo chamber. Should echocardiography and ultrasound be performed on every patient with pulmonary embolism? Dr. Farber, let's start with you on this one.
It probably depends on how good your radiologists are, okay? Because if you have really good radiologists who can give you a decent CTA and show you a RV to LV ratio, probably not. And most cardiologists hate like hell to be woken up at 3 o'clock in the morning to come in and do an echo. At some point down the road, yes, but not right up front, not necessary.
You do your own echo? No?
Huh?
Your own echo? Well, unofficial,
Well,
critical care
unofficially,
docs,
but
we do
no, I thought
this.
you meant like a real echo.
So you're saying what the audience does is not a real echo? Okay, just wondering. Dr. Gomberg.
wow. So
The cardiologist
I
can't agree with that.
appreciate that he doesn't want to wake us up. And I also appreciate that our intensivists can do a nice
Yeah.
4-chamber and tell me that the RV is really atrocious. And I think that says a lot more than that CAT scan. The CAT scan is not moving. You don't have any idea of chronicity. You just get a ratio. So it really depends on what you're trying to decide. Where are you in the scheme of the acute PE?
So should every patient have an echo ultrasound?
Yes.
Dr. Tapson.
Yes, absolutely. The reason is 2 reasons. One, ultrasound, you want to know what's in the legs, right? David Jimenez showed 2010, published in one of my favorite journals, Chest, that if you're
Point for sucking up. I got to give it to him, but don't go to that well too often.
hazard ratio of 4.2. You have acute P and concomitant DVT, hazard ratio for death of 4.2. Second reason is you don't want someone to get up and walk with iliofemoral DVT. You want them to go to the bathroom in the kitchen. You don't want them walking around. It's kind of like when this creek in my neighborhood overflows during a big rain season. You see logs going down the river. That you decrease cardiac output, big iliofemoral DVT, it goes to your lungs. You want an ultrasound. You want to know it's there. Tell people walk a little bit, don't walk a lot. Number 2, the RV. You want to do the echo, not just for RV-LV ratio, not just like Hap said, get a CT. You want that echo so you can see if there's clot in transit. Now there's clot in transit. About 5 to 10% of patients clot in transit imparts a death rate of 12 to 45%, and you want to be aggressive. AHA condones being aggressive with clot in transit. That's my short answer, but I'm trying to think of something funny.
Why are
now.
you looking at me? Look at him. He just
trying to think
threw
of
so
something
much
funny.
data all over you. You're buried.
I mean, you know,
You want both.
I just bought a 66 Toyota from the
Yeah.
guy.
That was
I
a
mean,
nice Corolla. That was a nice
the
Corolla.
only issue I would say is that a clot in transit isn't often seen by the
By the CT,
By the
right.
bedside guys.
or the by the bedside
Yeah.
guys. So then if you have any question of that, then you should
Yeah.
be getting.
Sure, yeah.
You
Yeah.
gotta wake Marty up at 3 o'clock.
You don't.
in the morning.
You got to get the echo. You got to get the echo. You do. We want these patients to do well.
I was
We
trying
love
to
our
be nice
patients.
to Marty.
That was so nice.
Don't be nice to people. In real life, you're not here. They're paying for blood. They want to see some aggressive. I know you're capable of it. I've seen it. So, all right, let's move on. Topic number 2, number, please. Is the diagnostic threshold for mean pulmonary artery pressure appropriate at 20 millimeters of mercury? What about a pulmonary vascular resistance at 3 units? Dr. Gomberg.
Yeah, so, I mean, I think this is kind of outrageous that we finally went back to what we did, I don't know, when I was a youngin', and just kind of gave
Last week.
a mean threshold. You know, I think I was in kindergarten when that thing happened. But, you know, guys, you can't now start to use the standard deviation and do it properly, because the reason why you guys said it was so that you wouldn't overtreat. So I think that it's just gone a little nutty because now we're relying on the science, but none of our clinical data relates to a mean PA of 20. So I think we should have just left it as it is.
Go, if you disagree, go at her.
So, no, but the craziest thing about this, if you actually use these numbers, I'll give you a quick case. So you got a person who's hypertensive, dyslipidemic, and diabetic. They're 5'6".
That's HFpEF, that's HFpEF.
Yeah, we don't need that, we don't need the diagnostic.
No. So they have a PV, they have a.
And they're
B-
80.
No, they have, I don't care how old they are, they have a BMI of 42, okay? They have a decent cardiologist who diureses the hell out of them. You cath them. Their wedge is 13, okay? Their mean pH 22, okay? And their cardiac output is 4.4. That gives them a PVR of 2.2, okay?
The wedge is still high, though.
So you're going to tell me that this person has PAH. In addition, if you actually do the math, this person has a cardiac index of less than 2, and
Yeah.
you're going to put this person on systemic therapy?
The question
that's
is just,
okay,
is the
it's fine.
diagnostic threshold 20? That's the question. COVAX 2009, European Respiratory Journal, right? 1,187 patients, 47 sites, 13 countries. PA pressure, mean PA pressure of 14, right? PA pressure of 14. 2 standard deviations above is 20. That's the diagnostic threshold. That's the question, right?
But the issue is that the people who have that lower, if you will, mean pulmonary pressure or the lower PVR, almost invariably, are going to have either group 2 or group 3. But the way the new guidelines are set, they now have true PAH.
Yeah.
So, are you saying the diagnostic threshold shouldn't be 20, or should be, what should
No,
be?
I
What should
don't,
be?
the bottom line is, I don't really know what it is, okay?
Thank you, thank you.
Yeah. Ladies and gentlemen, Dr. Farber has just said, editing carefully, the bottom line is, I just don't know.
This is
Okay.
not nice, this is not nice. Okay, we understand
We
that the
understand
math is there.
physiology versus clinical
But
shit.
now, when you go.
All right, no
when you
cursing.
tell
All right, watch the
these
language,
people-
Dr.
Oops, sorry.
Farber.
When you tell all these people that it's okay to treat with a mean of 20, that's just not okay.
That's nonsense. Plus, as pointed out, none of the studies have
And,
ever been
and
done
I,
on
you're
these
gonna now
patients.
tell me about all the patients, there's only 2% that changed their diagnostic when they presented at 2018 World Symposium.
So what's the
big
diagnostic
difference?
threshold? What's the answer to the question?
Well,
guys?
but the other point, Vic, is nobody,
What's the
really-
best answer? It's 20, COVAX.
All right,
And Mario
but
Super wrote a
hang
nice
on, but
commentary
hang on.
along with that paper,
Hang on,
right?
there's a difference between what your physiologic pressure is and what clinically you actually have and what you treat.
Yeah, exactly, sure.
Hey!
But what's the diagnostic threshold?
Well, hang on.
That's the question.
So the
I'm gonna call 20 seconds on this topic. I grew
There's
weary.
a difference between whatever
I like
you
it
want to
too, but
use
we have
as your
things to get to.
diagnostic number and whatever you're going to treat.
Yes.
And the thing I have is with these new guidelines, there are people out there in the real world who are going to start treating these people with no data.
Yeah, you know that when
You
you treat
know
a,
that.
when you treat a patient and their mean PA pressure goes to 30 from 50, you're pretty damn happy.
But that's not the question. The question is the
So wait,
diagnostic
so
So
threshold.
wait, like, yes or no?
That's not would you treat them,
So
would you not?
yes or no, Hap? Yes or no? Is this mean diagnostic? Do we need to change the guidelines, or are these data appropriate as
By the
written?
World pH Guidelines in the last meeting in Nice, what did they say? Yes.
Just because people say it's true doesn't mean it's true.
Thank you.
You can't thumbs up yourself, Dr. Tapson.
So Vic, under that scenario I gave you, are you going to treat that person?
I might. It depends
Oh,
on the patient.
give me a
Okay.
break.
All right, so
I've got a 40-year-old woman with dyspnea and a mean PA pressure of 22 PVR4.
But you realize then you need to do the PVR of 2.2 if you're going to use all the data, and that says
So is that
3.
the argument? It's the PVR? Is that the argument?
Well, you
Of
just
course
said the
big-
diagnostic
Well,
threshold.
PVR3, I mean,
So
we
what
know
about
the.
PVR3?
You're going to use it, are
If
you
you're
going
going
to
to use the
PVR
data, you have to use
too?
the data throughout the whole
The
thing.
question is, what's the best answer? The question is, what's the best answer to the question? That's the official answer by the World pH Guidelines.
audience, hot take, thumbs up, thumbs down. You good with that argument?
Come on, you guys. Thanks. Love you all. Love you all.
Love you all. All right, it's about 50-50. All right, I'm going to leave the scores as is. We can come back to this if time allows. We have things to get to. Liverly dilate is our next category. Should all patients undergo vasodilator testing at initial evaluation? Dr. Tapson.
I would say no. Nowadays,
my
okay,
God.
hold on.
Okay,
hold on a
let him answer.
I love the original data by Stuart Rich. Are we going to use calcium channel blockers? I mean, when's the last time you used diltiazem on someone? I think we've got really good drugs now, way more data on our other 3 categories of drugs than we do for calcium channel blockers. So I would say no, not everyone, not everyone. Should all patients? No, not everyone. Should a portal pulmonary patient? No, you don't want to give them a vasodilator, a portal pulmonary at their cath? No, you're not going to do that. So should all patients? Absolutely not.
Dr. Gomberg.
So I unfortunately agree with him.
I might have to take a point away for agreeing with him.
But I will say that you do need to do it more often than people are, because if you miss it, you're really putting that patient in a very different circumstance. And there are tons of patients that you get that are on oral therapies that are actually calcium channel blocker responders.
So
I mean,
you
if
agree
you
that
see-
not all do? We
I
agree, Marty, we agree, right?
I agree. I'm on your side this
Thank you.
time. But, it's a
We gotta
rarity.
get- we gotta get-
Farber, do you agree on this?
Team up.
You don't agree on anything.
I don't agree. No, I unfortunately have to agree with the two of them because I'm notorious for not doing it, except, so there
You're
are
notorious for not doing it, but you agree?
No. So the vasodilator studies are basically, in my mind, are people who clearly you're not going to put on systemic therapy to start with, people who fit certain categories, or the people unless you're doing this all for research, fine. But in general, are you gonna do somebody? You're not going to do a vasodilator trial on somebody you catheter as a wedge.
Cardiac index,
Yeah.
cardiac index is 1.5. Are you going to do it? No, you're not going to give someone a vasodilator. You're not going to do it. So should all patients? No.
Actually, I hate to agree with
It's
Marty,
not a-
but
not a-
Marty's
Stop
point-
manhandling the other contestants, Dr.
Marty's
Farber.
point is actually well taken, and people who have like idiopathic PAH or heritable or drug and toxin, every once in a while, if you don't do it, you're going to miss somebody who actually is calcium channel blocker. And the case I always used to bring up to do some of the patients you wouldn't think of doing is I have a guy who has truly sickle cell PAH, no question. He's had it for 22 years. And back then, we were doing vasodilator trials on everybody. And he dropped his mean pulmonary pressure from 50 to 22, and he has been on a calcium channel blocker for 22
But should all
years.
patients undergo vasodilator testing?
No.
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 All right.
Just
Hey,
clarify.
we
We're
all-
done. We spent a long time coming to full agreement on this topic. Moving on, CTEPH Curry is the next one. Is ventilation perfusion scanning still the best test for CTEPH? Dr. Farber.
Depends if you're a radiologist or not.
That's the second time
radiologists don't believe
you've
it.
gone to that.
Yeah, yes.
Yes. That's all you have. Okay. Dr. Gomberg?
So just to be the contrarian, I'm going to say no. And
And
I'm
what-
going to say that because.
Based on what data?
Because most places don't have VQ scans, and through all of COVID, I couldn't get one because nobody was doing the ventilation
Yeah, but
part.
that's a
Wait,
special
wait.
instance.
I want to do an audience poll. Most places, the assertion on the table is most places, so agree or disagree, most places do not is this assertion.
Oh, okay, well.
Wait, during COVID.
During COVID, that flip it around? Okay. You went from a grossly negative to a grossly
I said
positive
during
response.
COVID.
You did.
Jesus.
You did.
And
You only said-
do we think that it prevented the diagnosis of CTEPH? No, the answer is no, we didn't.
It's the best screening test, but then you need a CT scan. You can't determine operability or whether someone gets BPA based on the VQ. So the VQ is the best screening test. You got to do a CT, and ultimately, some agree you still got to do a PAgram.
I
So-
think most surgeons would agree.
So I think a PA-gram is the better.
So it's the
You
best.
still
It's the
need a
best initial
PAgram if
screening
you
test
do
because if it's
surgery.
normal, you're done. It's not CTEPH, right? It's not CTEPH if it's normal. So do that. Save the patient some more tests.
So aren't these
It's normal.
patients getting CAT scans anyway at some point in their workup
Yeah,
generally?
exactly.
So then,
Exactly.
in that context, what's the point of a screening test if you're going to go on to the
Dave,
second
you get 2
test?
points for that right there.
Thank you.
No, but
And what happens in the ER?
they get a CTPA the minute they walk into the ER.
Right.
Well,
So
not
they
for-
just
not for-
say-
not for
if they just say,
CTEPH, that's
"Oh my
for
God,
PE,
the
but not for
troponin
CTEPH.
is a little bit positive,
The
like
D dimer is
0.13.
51.
Yes.
You're getting a CTA.
There you go.
So
Right?
back to the question.
You stub your toe.
Everyone has said you're getting a CTPA. In that context,
Then
should
why
we be
do you-
doing VQ?
It's the
Maybe
best
the best
screening.
test. Should we
It's the
still
best
be doing
screening
it?
test, but it's not the best test, as the question's
Fair
worded.
enough.
Just
Wait,
with-
Screen.
So does somebody,
don't- you
someone's
don't
got
walk
PH, so they have
on
CTEPH?
It's
Let's do a
not-
VQ.
so
don't
you
walk,
agree
right?
with me, it's
You
not
don't
the
walk
best
into
test.
an
I agree,
ER
it's
and
not
get
the
a
best test, yeah.
VQ
He
scan.
agrees.
It's the
not-
best
with me,
initial screening
it's
test.
not
We have
Marty's right
VQ
on.
scans in the wellness center if you go over and look, I think. We do not. For those in the attendance, we do not have VQ scans. Okay, moving on. Next topic. Take a walk. Is 6-minute walk a useful diagnostic test or an utter waste of time? Dr. Gomberg.
This is, to me.
Oh, I heard some groans from the audience. I apologize. I've disturbed the
So,
audience with
you
this
know,
question.
One of the first things that I did was a 6-minute walk test versus the treadmill test. Now, I know that I have an audience of pulmonologists, and why would we do a treadmill test where, we only go to the gym and have our home Pelotons that are telling us how many METs we go? And it's because, and now it's even more real, that the 6-minute walk has its limitations. You can only walk so far. And we see that, and now we don't even often have a cutoff for the entry into our trials. I think we need to move away from that 6-minute walk test finally and move on to something that's truly a max test, not a sub-max test.
Dr.
So
Farber.
I think it's a waste of time.
Hap.
My turn?
Yeah.
Okay,
well,
forget it. Rick.
As somebody who,
Hey, you lost your turn. It's fair.
Sorry. So the 6-minute walk is a useful test, and it's not a total waste of time. It's a useful test. It's not the best test in the whole world. Maybe everybody doesn't need it. I mean, I don't need one right now. It doesn't say anything about who needs it. But for PH patients, it's a good test. It's a useful test done correctly in the clinic, good hallway, good sats, your personnel doing it the correct way. It's a useful test. It's not the
What does
best
it
test in the
add?
whole world.
What does it add? So it's a useful
What does
test
it
implies
add?
that you're collecting some data, you're using it for some purpose.
What
What's
it
its
adds
role?
is the distance someone can walk in 6 minutes.
Yes. Okay. And so,
Is that more sensitive, specific, useful, additive?
I
And
would argue that your one with the cardiac index of 1.5 can still walk 400-something meters.
Well, I mean,
So then what does that do?
Well, it doesn't mean everyone needs the test, right? Everyone might, but there's some people, I think it's very helpful. You want to follow how they're doing. You follow these patients, you want to see how they're doing. I want to know how they're doing. It's one part of your assessment. It's not everything. But it's a useful test.
Hap,
It's
jump
not
in.
a total waste of time.
if you're waiting for him to stop, you're going to be waiting a long
No,
time. Jump in.
This guy's selling mattresses now. He sounds like Mike Lindell, the pillow guy.
All right, you got points the first time you went there. You're not getting keep winning points every time you call him a
All right,
salesman.
As the person who wrote the paper about that 6-minute walk improvement sucks, but if you fall 15%, that's really good. That's the way I believe it should be used. The problem is, in a place like where I work, where 2/3 of my patients are connective tissue, like scleroderma patients, a 6-minute walk is really unreliable because they have so many other reasons that they can't walk.
So it's
okay?
a total waste of time, you're saying?
So it's a total waste of time?
Or is it a useful diagnostic test?
It depends on the patient.
You've
it's a
said
useful
every question
diagnostic test in
depends.
general. Not for everyone.
Also,
It's not
also,
for everyone.
I mean, I can tell you there are certain places where it's done poorly.
Yeah. Are you going to tell me
Okay?
that you
I
can't
mean, I
tell
know a
looking at
place,
the
not to
patient?
name it, but in Boston where the 6-minute walk ends where the cafeteria lets out. Okay? No, so they go, right, no, so I think overall, at its time, it was a useful test. It now has become less useful as things have moved on to other things that are clinically more important, like hospitalization,
I mean,
things like that.
do you think you should be walking these people with canes and walkers?
No.
And- I mean, because that's what's happening.
I know, it's ridiculous.
So it's not a required test. So it sounds like there's a general
Not a
consensus.
date.
It's useful, but
that's
in the
another
right
2
case.
points for
Like
Dave.
everything else,
Thank
if
you.
go back, it's lost its usefulness.
Audience, thumbs up. Useful diagnostic test, thumbs down, waste of time.
Oh, guys.
That's what I'm calling it here. So not a diagnostic test. The audience is actually learning and reading the question. So Hap, I'm going to give you a yellow card. You didn't know, but there is a rule that we had to put into play after Atul Malhotra was up here referencing his own manuscripts multiple times, that we yellow card you the first time. If you keep doing it, you will red card. So that's okay. It's good to be self-referential, but
It's good to know.
yes, that's why I'm warning you all. It's nobody loses
Well,
points the first
nice
go
coming
round.
up with the rules later.
No,
You lose a point. I'm allowed to change the rules. That's the beauty of being chess president. Let's move
I'm
on.
going to bring up, I
You-
want to be a millionaire.
That's fine. Feel free. All right. Next topic: exercising your demons. Does exercise-induced pH exist? Is this a real thing? And if so, how would you define? The groan from Dr. Farber tells me I need to go to him first.
So I believe it exists as an entity. How to define it has defied definition. Okay, I think the current definition that was put forth in the guidelines is horrible. Okay, because it's based on a single study of which it's all people with left heart disease. Okay, so I don't know that it actually has any relevance to true PAH patients. How you actually define it, just to define it with a change in mean pulmonary artery pressure is not sufficient. In my mind, if you really do have exercise-induced PAH, you will raise your pressure, but the main thing is what happens to your PVR when you exercise. If it stays the same, or certainly if it goes up, that's evidence of pulmonary vascular disease, okay? And if your wedge doesn't go up with it, there are people, especially some of the scleroderma patients that you catch really early who have what looks like exercise-induced PAH.
Colleagues?
So I would argue that it's just part of the continuum.
Yeah.
I mean, as you age, your resistance goes up, right? In the body, systemic. In the
But your
pulmonary
resistance
circulation.
still go down. when you exercise.
Yes, understood. But why can't it just be that some people have abnormal reserve in the pulmonary circulation versus others? I mean, as a cardiologist, and I know that's going to get me in negatives.
No, it did not, yet.
You know, we've done this. We know the microvasculature plays a role. Does it warrant a PAH diagnosis? Do we know that our drugs treat it?
Oh, I didn't say-
No. So I think to give it its
Can I
own
talk?
entity, no.
Let her finish. You could always jump in, but I like what I'm hearing. Go.
To give it its own definition as this, you have exercise PAH. I think that if you see what's happening, it was with the cath. Are we looking at the blood pressure? Are we looking at the heart rate?
Everyone has exercise in pH on their way to getting pH. And in some people,
That's not- you don't
they
know
stop.
that. Now you're just.
You
Oh,
do not
you have
know
to.
that.
You have to. It's kind of like you can't have PE without DVT, except from a few other places. But I mean, bottom
Except,
line is,
okay.
if you have exercise-induced pH on the way to getting pH,
That is so not
you
true.
have
I
to
don't
bump
know
with
that.
exercise. You
You
can get
cannot.
resting pH
That-
without ever getting it with exercise. You walk 10 feet.
So
You
then
don't.
you should just test everybody.
Yeah, you're going to get it on the way to get, and then some people stop, and they're functional class 2, and they're
Hey,
treated
that-
and never get
No
worse.
offense, but that's freaking nuts.
No, it's not. No, it's not.
Continue. So,
That's like
any
you
data?
have exercise pH.
No, I don't. But if I'm going to get, I'm saying not everyone has it. Everyone that gets pH has it on the way to getting their resting pH. Yes, you can. How can you not? How can you not?
There's no evidence on the mean pH
Oh,
pressure. There's no evidence.
The frickin' world is round you guys. Come on.
No, it isn't.
On the way to getting resting pH,
Kyrie
you have
Irving
to get
says it's
exercise pH.
flat.
Some people stop there and never get rest pH. Some people keep going and get functional class 4 resting pH. It's a continuum. It's a continuum.
I'm going to put a whole audience. What's your take on that? Is it likely that people have exercise-induced pH on the way
How
to
can
getting
you not?
regular
How
pH?
can you not?
Thumbs
Now
up,
you
thumbs
guys are
down.
looking into his eyes.
You have
Don't
to.
look into his eyes. God.
Look, they're looking into his eyes. I gave about 60% thumbs up on that. So why is the audience wrong?
Well, the problem is you may or may not be right, but there's absolutely no proof of it, and there's no way to prove it. You're not going to cath every human in the world and say, okay, we're going to wait around
But do you
for 5
think?
years. And
Do you think he's right?
The doctor of pH
No.
they call HAP could cure your pH in a snap. When it comes to debate, he's good, but I'm great, and he knows that I'm not full of crap.
Wow.
wanna say-
And I don't think he came prepared with that. I don't know. Did you? I don't want to know. I prefer thinking you
wanna
didn't.
say that.
So you can't prove it. Do you believe it? That's the question. Do you
everybody has
believe
it?
it?
No, I don't.
No. How physiologically is that not likely to be true? 'Cause I'm not a
How can it not be true?
vasculologist,
So this is-
but
wait,
teach
hey,
me.
This is the same thing as if you actually look back and you look at autopsies of people who don't have pH, okay? People like, especially scleroderma people who don't have pH, a lot of them have vascular changes that look like they have pH and they never develop anything.
Well, then they don't have resting pH. They don't have exercise pH. You
Yeah,
can't,
but then-
you,
wait,
you
wait,
can't
they
get to
have
the
the
resting
histology-
point
well,
without
hold on.
going through
So
exercise.
now
So they have the
So-
histology.
You bump your pressure with exercise before you bump it with rest. Sorry.
So
It's a
they
fact.
have the histology that looks like pH, but they never develop it. So I have no idea what you're talking about. Actually, neither do you.
But the thing is, we don't diagnose it on the way. We miss it.
He does.
He says it with
Well, see,
authority.
he talks real
We don't
fast, so
we don't
nobody can
diagnose it
understand what
on
he's
the way to
saying.
resting pH. We don't, because we don't. Patients get resting pH too quickly. We don't always say, "Oh, you've got resting pH now." We don't diagnose it, but they have to have
So
it.
what you would do well is the movie Back to the Future, and you would go back and cath all these people that show up and prove
No,
it.
you don't. It doesn't help to do that.
Besides
It doesn't help to
pH.
do that. We don't need to do that. We just know it's true. It doesn't matter.
I'm sure we're coming back to this topic later, Dr. Strauss. Fair to say? Oh, he nods yes. All right, let's move on to ejection day. How should we diagnose pulmonary hypertension in the context of heart failure with preserved ejection fraction? The second time we're hitting HFpEF today. Dr. Gomberg.
Yeah, so I would say that that's definitely, if we're really looking for pulmonary vascular disease in a mixed component, then you need to do the cath. I don't see how to go about it. We can add up all the echo criteria and diagnostic
HFpEF2,
phenotypes.
all those.
It's very commonly a phenotype,
I
but yeah, you
guess-
got to
but
cath.
here's
Sure.
the thing. Again, although Vic doesn't care about treating patients, he just cares about the definitions. Since we actually will likely have medicines for this, then you want to make sure you're treating the right people. Do I cath 80-year-olds with diabetes and hypertension and a BMI of 50? No, because I know what the answer is. But if you have stuff, like if you really want to know what it is, then
So you need a cath most of the time, but sometimes you don't need a cath. Is that what you're saying, Marty? I agree with that. That makes sense. It's a phenotype. You look at the phenotype, that's probably HFpEF, and then you do an echo. Oh, the EF 70%. This is really probably HFpEF, and then you decide to do the cath or not, depending on the phenotype.
Yep.
Well, we all agreed. We all agreed.
Well, I haven't heard from Dr. Farber yet.
Well, I was just going to answer that. I mean, I think the problem here is severalfold. One is you have no idea of the HFpEF is just too many phenotypes all rolled into one, okay? And that's part of the problem is we have not defined the phenotypes, okay, for one. Okay, and you can't tell me.
I don't know if that's the case. I
There's a
think
nice general
but you can't
phenotype.
tell me
Obesity,
somebody
diabetes,
Shaw
hypertension, a
has
pretty good
very
phenotype.
nice
No, but you
review
can't tell
insert,
me
and you
that
can see
somebody
there are
like with
10
scleroderma
different-
who's really thin and all this is the same phenotype as somebody who's got the BMI of 40 or whatever. The second thing is, if, in fact, you diurese somebody really well, I can make them look like they don't have HFpEF.
That's pretty mean.
Which is
to do that, because you don't want to make them look like they don't have HFpEF.
No, but.
You want to get the right answer.
No, but what I'm saying is, in the real world, a lot of the patients you get referred in on treatment are people who've been well diuresed,
Yes.
okay?
Sure.
And they've been started on meds, even though
And so what are you going to do? You're going to cath them.
Right.
So we diagnose it by looking at the
No, but I think-
phenotype, looking
I
at
think
the
the
echo,
one point
making
that Marty
decisions,
made
and
that's
considering a
really
cath.
good
Right?
is, unfortunately, you can use any echo criteria you want. You can use any of the scores, okay? But when push comes to shove, if you're not sure, you need to know the answer.
See, look at he's giving me compliments again.
Yes.
No, I'm
I
not.
don't know.
I feel like you're all taking the same journey, and the two of you on the far side get right there, and Hap sort of wanders around for a while, and then
wanderer.
comes back around and meets
Yeah,
you
but
at the
that's,
end.
that's just the drugs kicking in.
He's
Right.
a wanderer.
See, there's a point.
Somebody beyond this one.
Self-deferentials are at the point. Let's move on. The clot thickens. How important is clot burden in stratifying pulmonary embolism, Dr. Tapson?
I think it's important. It's one feature, right? I mean, you can't if you have extensive clot burden, if you block every PA in the lung, you're going to die or code or something. So I think there's a nice paper by our colleagues from the Netherlands, Vandermeer, 2005, and Mena Wiesman was on that paper too. And they found if you have acute PE and your clot burden is more, your obstruction index is more than 40%, your mortality is 11.2-fold increase over the next 3 months, and that's PE-related mortality. So clot burden does matter. It's not the only thing. RV function matters, vital sign matter. Clot left in the leg matters. A lot of things matter, but it's important. We always look at it. You can make decisions sometimes about a patient with clot burden, just a few other parameters. It definitely matters.
Dr. Farber.
Okay, Inari breath.
I'm still at Cedars. I was on PERT last week, by the way.
I think the major thing about clot burden, there's no way that if you obstruct the vessel, the burden of what you obstruct isn't important, okay? But the thing that's
So we
important-
agree. We agree.
No, hang
No,
on.
he just said it
Oh,
doesn't
you don't
matter.
want to agree.
Calm down. So
He's a
the more
clot burden.
important
It
thing
does
to the,
Doesn't matter.
the thing that's equally important to clot burden is how well or not your right ventricle can handle that clot burden,
Of course, yeah.
okay?
Yeah, that's true and false, because if you've had multiple PEs and your RV's already compensated,
Then you can handle.
you could have a high clot
No, I
burden
agree.
and your RV's compensated. So I think that what you're trying to say is clot burden matters.
It does.
It matters. If you have
But we
subsegmental
can't-
clot
but wait,
versus
now.
extensive bilateral
How do we
PE,
measure the
there's a
clot
difference. It
burden?
Dr.
matters.
Tapson, give him a minute. Let's go.
No.
Dr. Gomber, you're
Yeah, I
you're
just
on.
think the
Marty.
problem is that we don't, I look at a CT and I go, oh, there's a high clot burden. But how are we actually measuring it, and how is that factoring in?
No.
Miller Index or Connolly score, just
Yeah,
just
but
or just
hang
your
on,
gestalt,
Rick,
just your gestalt.
There's
It's a
no
gestalt.
really good way. I mean, even our interventional radiologists will say, geez, there's a lot of clot in there. They're not going to say, that looks like about 42% of my.
No, they say, geez, there's a lot of clot in there, and it's important.
Wait, but sometimes the CT doesn't show a lot of clot, and there's actually a lot
Yeah,
of clot.
and it also depends if it's proximal versus distal, because you can have a ton of distal clot and not see it.
But what was the question? Does clot burden matter,
That was
right?
the correct.
It
Yes,
matters. It matters. We all agree. It matters.
eventually matters.
It matters.
It matters, period.
It matters. We agreed.
You keep getting
See, here it
pulled
goes.
over.
He went around.
You got there. All right.
No, you just get there in a different route.
Intermediate lytics is the next topic. Should intermediate risk PE undergo intrapulmonary lytics and extraction? Dr. Farber, let's start with you. Should intermediate risk PE undergo
Okay.
lytics or extraction?
So this is the one that has people who do PERT teams ripping their hair out, okay? The data suggests, although the data aren't good, there's only one controlled study that suggests that if you have intermediate clots with any kind of evidence of, or if you have an intermediate status. The people who are high risk or low risk are easy, okay? The people, it's sort of like PAH, the people in the middle are the hardest, okay? So my gestalt actually is that you do need to be more aggressive, especially if they have evidence of right ventricular dysfunction.
So are you doing intrapulmonary lytics on your intermediate risk?
We don't, we actually do thrombectomies. Okay, because, no, no. But for a reason, because our radiologists and me, okay, are much, I think that the age of lytics is like the 6-minute walk, is headed out the door and down the road.
Agree.
And past. Because there's no reason, if you have a better system potentially, to expose somebody to the risk of lytics, even though it's smaller if you do it intravascularly than systemically, why do it?
Yeah, so what I'm going to say is that I don't understand why folks don't treat this like a heart attack. Because if you don't get all the clot,
So then you
just-
pull it out.
but whether it's intrapulmonary lytics versus, extraction, I think it's going to depend on the center. So yes, I would use intrapulmonary lytics for intermediate patients, and I do. And I don't base it on like, oh, but their oxygen sats are fine and they look fine.
No.
It's like, if this were my family member, I want it out.
So
And I-
regardless, you're taking it out regardless
I'm
of any
taking it
clinical
out. I don't care
symptom.
which way it is,
Yeah.
whatever the IR is willing to do. I think in centers where the interventional cardiologists are doing it, there's more aggressive. I think that patients get back to work. I see them all post,
But you
and
wouldn't
they
do-
get
you
back to
wouldn't
work
do-
faster.
You wouldn't
They,
do a thrombectomy in a low-risk person. even though
I didn't say
even-
low risk.
but
We're
wait,
talking
there's still
intermediate
clot there,
risk.
so
I
you're
know,
not
but-
gonna- You're gonna
but-
leave it behind.
But we know that the low risk has a good outcome and that we can treat it with our current therapies.
Dr.
So-
Tapson.
Well, I agree with my colleagues here. I think we should be aggressive here. If you look at the data out there, look at the mortality of intermediate risk patients. We divide them, by the way, into intermediate high and low, right? Intermediate low risk means your trope or your RV is abnormal. Intermediate high means both are abnormal. If you're intermediate high risk, data show your mortality is 10 times higher. 10 times higher than if you're low risk. And that's PE-related mortality. That's Cecilia Beccattini's study where she went through. And intermediate low-risk patients, by the way, had a mortality 4 times higher than low-risk patients. So these patients need to be looked at. They need a conversation. And I agree with Hap and Marty that most of them should be considered for aggressive therapy. And we published the FLASH 800 data. 800 patients, large bore thrombectomy, mortality less than 1%. So you got to look at the
Did you
data.
say
But it's
we
not
published?
controlled.
Did you
Well,
say we published?
yeah, we, sort of.
not
Me and
Is that the royal we or you?
No,
Is that the yellow card? I may yellow card him,
I
yes.
meant we as a group. We as
Okay.
a, we as a
No, but
world.
I
Oh,
think,
okay.
that-
Not
I think,
me, not
I
me.
think there's another point to keep in mind too. So what we have mostly is we're basing decisions, or we used to base decisions on data that was old, okay, and technology that was old. And as the technology has improved as far as getting the clots out,
Yeah.
I think most of us
So-
would
so-
agree.
so
with-
Great point,
what's
great
What's
point.
it going to take to make it so that the PERT team is like the acute MI team?
No,
That it's time to getting it out? Because
what we do.
That's where I'm at.
That's
That's
where
what
we're,
And I don't-
that's where we're headed.
But I don't feel like,
Well, our hardest thing at the beginning was to get IR on the same page of let's get these things out.
and then I would argue that quality of life is making a huge difference, and we're not looking at it.
So I want to go to the audience here. What, again,
Well, wait, there's one other point.
Go for it. All right.
Some need
So
clot
the other
extraction,
point-
some
the
don't,
point is,
some don't.
Aside from what we're talking about initially, the real question is down the road, do we do something that prevents people from going on to develop CTEPH? Which
Yeah,
we
but
do
it's-
not know the answer to.
We don't know.
but
Yeah, I think it's irrelevant.
But we do know that RPVO predicts increased mortality and increased recurrence rates, residual pulmonary vascular obstruction, even without CTEPH. You have and that's our Bonnefoy data. All the European data suggests that leaving clot that persists in the lung is bad. But we don't know yet whether getting it out up front
we
will
don't know
matter.
the reverse.
It's a nice hypothesis.
So in that context, in the audience, thumbs up, thumbs down, how many of you are currently, not maybe want to, if you're currently performing one of these procedures on your intermediate risk patients? You can get some paddles for those of you in the back. We have the thumbs up, thumbs down paddles right next to you. So it looks like about 75% are actively doing this. Does that surprise you?
No, actually, over the last couple of years, it's more, since I consider myself sort of an interventional pulmonologist, and IR
Or a
and
frustrated
cardio.
cardiologist.
Oh, exactly.
Yeah, he is
right?
not an interventional
We-
pulmonologist, ladies
we
and
do-
gentlemen.
Because they're not hard to do, and they're,
No, so I would say that in the 75% of folks that actually do it, do you have to push to get it, or are you like the last case of the day? Like, are you the last case of the day because you're looking okay, or you immediately open up the lab? And I bet it's that you wait till all the elective procedures are done.
If you're high risk, you do it right away. If you're
High
not high,
risk
if
is
you're,
good.
if you're
Yeah,
intermediate
I
risk,
get it.
usually you wait, and it's probably reasonable to wait.
well, the hardest
I don't
part to
know.
get IR was.
What are you waiting for? If you're
Yeah.
going to do it anyway, I mean, other than the
For
fact that you
them
don't
to
want to
get-
wake
for
up
the IR people to get
IR
done
people
with
at
the
3 in the
earlier
morning.
cases.
The reality of it is, the hardest part to get done is if it happens at night or over the weekend, and the IR people say, they look pretty stable, we'll do it tomorrow.
The cath lab opens.
I'm
You
just
just
saying.
gotta open
It's
it.
usually pulmonary that says
No,
they look
we've actually
okay,
started
Yes.
doing
and
it.
IR wants to do it.
All right, I'm ready. Move on. All right, we're coming around the final turn. We're in a three-way tie, folks. So we're going into triple play. Should PAH patients be on triple therapy regardless of clinical response? Dr. Gomberg-Maitland. He cackled it. So I'll give him a point. I like the cackle.
I'm going to be honest. If we want everybody to go into debt and without the evidence, if your PVR is normal, there's no reason that on 2 therapies that you need to add a third just to add the pathway. It kind of reminds me of when folks were on oral Bosentan and they had 0 objective evidence that they were responding, that we just added because we were afraid to take it away. When in hypertensive disease, when things don't work, you just stop it and you move on. So to me, just starting everyone on triple therapy is just nutty.
Dr. Japson.
I think Marty summed it up very nicely, yeah. I mean, we first of all, we don't want to start everyone at once on triple therapy. We want to make sure, there's side effects of their drug, add another drug. We've got the ambition study, but we don't have the ambition study for 3 drugs yet. So,
In fact, it failed,
yeah,
right?
exactly,
So
yeah,
it
exactly.
failed. The
That's the
failed.
SITBON paper, yeah. So not everybody, and certainly not regardless of clinical response. If you've got someone three drugs and they're not responding at all, you don't keep them on a drug they don't respond to. It takes good clinical detail, good clinical care, and you make that decision.
The bottom line is there is no proven or robust evidence that starting people on 3 drugs at once is beneficial. Okay? We might believe it in our head that it makes scientific sense, but there's no evidence for it.
We agree, we all agree on that.
Where-
We should all probably get the
He's
same
going to
amount of
find
points for
something
that
he
question,
disagrees
too.
with. Go
No,
ahead,
but-
Hap.
So I think to extend Marty's point about the money is also, you have to remember that the more drugs you pile on, there's more likely to be side effects and drug-drug interactions, and especially in some of these patients that are misdiagnosed as PAH and actually have left heart disease, all of a sudden they show up and they're in floored left heart failure.
Maybe that makes me say a PH doctor named Marty
All
says
right.
PH treatment should never
Now
be
I know
tardy.
you just came
She's
prepared.
a brilliant, great doctor, a researcher who rocks. She's a PH expert and smarty.
I like it.
Thank you.
Should I give him the point for that? We know he wrote it yesterday
Oh,
or
I
2
did,
weeks
I did.
ago.
I wrote it yesterday. I did.
All right, they're giving you a thumbs up, so I'm going to give you the point back. I took it away, but let's move on. 3 topics left. Well, IV never, are we underutilizing intravenous therapy in PH? Vic.
Absolutely.
I think we are. I mean, when
Absolutely.
somebody, I'm not going to say who, published the paper, the Flowland paper in 1996 New England Journal, nice paper. I mean, we learned. Where's Abby? Abby's here. Where's Abby? Abby and I,
Abby's
we
here,
treated
huh?
a lot of patients. Abby and I put 600 people on IV prostacyclin therapy. I mean, the bottom line is, yeah, Abby did.
Abby gets a point.
It was
Abby,
Abby.
come on up.
Abby gets a
It was-
point.
It was Abby.
He gets it.
That's true. It was Abby. She did all the work. I tried to get the credit. Bottom line is, this drug works well. What do we do in cancer? We don't sit around and wait for something to happen. We give them induction therapy. We blast them out of the water. IV therapy works really well, and yeah, it's a little inconvenient, but it saves lives. I think we're underutilizing. I think we should be more aggressive up front with people. Maybe we put them on, maybe we stop it in a year, but be aggressive up front with these patients.
Dr. Farber.
These are human lives.
As somebody who probably uses more intravenous
I know,
systemic therapy
it's a
than
packed
anything,
panel of IV, but
Yeah.
that's,
I think people actually, when there was only one drug around, okay, I'm convinced that people actually did better, okay, because they all got
Yeah.
intravenous therapy. And I think the thing that's most rewarding or most telling is the fact you can put somebody on intravenous therapy, and within 48 hours, the difference is just unbelievable in time. So I think it's underused for several reasons. One, we've gotten into this situation where physicians don't tell people the truth, okay? They go, we'll put you on this oral drug. You'll be okay.
It's
And they-
inconvenient for the physician and for the
they-
patient,
and
and
they
so
go,
people don't do
We're
it.
only going to use intravenous therapy as a rescue.
What's their motivation for lying?
I have
Out of
no
curiosity.
idea.
No, I think it's a.
Hap
that-
is saying
that
you're
they
all
don't
liars.
wanna-
I don't
you
like
know,
it. I don't think you are.
Yeah, I mean, nobody likes a crying patient
Yeah.
in clinic when
And
you're
they
just
go,
meeting
"Well,
them.
you'll have
It-
side
it's not,
effects, you'll
it's
have
not
a
good
line,
form.
what the
It's
hell?"
not good form. So what I would say is that I think that right now, we are fortunate to have other options.
Right. Oh, yeah.
And that sometimes surprisingly, and I will say that, now it's been over a decade that we've been doing dual combination up front, that I've been surprised that some people do really well.
yeah.
But the problem is that
That's in
we're all
retrospect.
biased, because I inherited a huge IV practice, that we still have patients that we started 15 years ago that are
20,
doing fine,
20.
20 years. And so, it's one of those things where we've always wanted to do sort of an induction therapy, and we're clearly,
yeah.
but here's the thing, Hap. The problem is that now there's so many sites that have no idea how to use IV.
Absolutely.
That
But-
they
but-
don't even think about it.
So we are
And
underutilizing it.
that's-
I mean, there's people out there that should be on it. We're underutilizing it.
No, we all agree on that.
We agree on that, yeah.
I think the issue too is that we have been hoodwinked, some people, into believing that other modes of therapy, okay, are going to be just as effective, where clearly they're not, okay? And you would love to have easier therapy, but you don't. And the one thing Vic has said, the entire thing here for the hour is true, is the fact that you should treat this disease like you treat heart failure, left heart failure, like you treat HIV, like you treat cancer. You get on top of it first, then you can back out. It's not.
Thanks, Hap. Thank you,
never-
Hap.
No, you never want to get behind and then try and
Yeah,
catch up, because
exactly.
that's almost always going to be a failure. I
move
mean,
on.
how many patients
Yeah,
have you
but
guys seen?
I- like-
that
I
get
completely
sent in
agree.
And they are
Yeah,
now functional
absolutely.
class 4 and florid right heart failure, and they should have been on
I
IV
feel like we have
therapy
consensus.
before.
Any closing
do.
remarks? 10
We do.
seconds, anybody?
Closing
No?
remarks
On this topic, on this topic.
No.
No. Okay, moving on. Ilio killed the radio star. Should acute symptomatic iliofemoral DVT be treated aggressively? Dr. Gomberg-Malin.
Well, I mean, if you're
I'm
gonna.
glad they started with
yeah,
you.
I think if you're gonna treat your PEs aggressively, you should just be aggressive. But I guess, again, like everything in medicine, it depends on the patient. But I would treat it aggressively, because I don't want it to go all the way up into my lungs. I don't even need any
I agree
data.
with Marty. I think we should be aggressive. And again, there's other things to take into account. If someone's 90 years old, iliofemoral DVT, maybe shouldn't be aggressive. We have good techniques like that Hap referred to earlier, not just lytics, but clot extraction, the clot retrieval device. You can go in there and get this clot out easily. Even chronic clot, we're getting extracted now. It's a new era for DVT. It really is.
So-
But I think we can be aggressive now without lytics and do
And it's
our
much
patients
better
a great
to do it
favor.
acutely than it is
I'm going to come to you in a second. So by aggressive, you agree with the mechanical interventions?
I do agree
Okay.
with mechanical intervention,
So
not systemic
I
lytics.
think just to play a little bit of devil's advocate and temper it, not that I don't agree that if you're going to,
Either take one side or the other.
no, hang on, keep your short.
He doesn't know what side he's on yet. He'll figure it out in the next minute or so.
No,
I
think
can't
the issue
wait, it's like an anticipatory.
Well, that's what I'm trying to do here. No, I think part of the issue is, although we do agree that we want to be aggressive, unfortunately, at this point, we don't have the data to back it up. But just as a little bit of a temper this down. But now, because of the ease of doing this, we're all going to do it and probably never get the data to prove that what we've done is actually beneficial.
So we learned in the Attract study, it was a kind of a failure of a study, but we did learn that subcategory of patients with iliofemoral DVT have a lower risk of post-thrombotic syndrome. So I think it makes sense for post-thrombotic syndrome is a painful chronic process. We don't want our patients to suffer. So I do think for that reason alone it makes sense. But now, even since Attract, we have better techniques. Clot retriever data has been published. We have better techniques. So I agree with my colleagues. We should be aggressive here.
Audience, thumbs up, thumbs down. Treat aggressively in terms of mechanical extraction. Thumbs up. If you have your little paddles. Those who are holding up, I would say about 80%. Well, still about a 20%.
I will
There's a
tell you-
vocal minority.
I will tell you, in the real world, that is a little harder to get past your interventionalists than doing
Fair enough.
clots in your lungs.
It's
There-
more
there is
convincing
no
when someone's
question.
very symptomatic. If they have phlegmasia,
that
it's
is a
easy,
very
but
hard thing
very
to sell
symptomatic.
to them.
Sure, yeah.
Final formal topic. Mistakes were made. What single mistake is made most commonly?
Consulting Hap Farber.
Wow. I was going to go to you first, but I'm now going to go to Hap to let him defend
letting
himself.
Vic talk is
Actually, I agree. Unfortunately, I agree with him.
having Vic's mic on.
All right, let's get the answer right. Well, everyone's gotten points on the smack, and I love it. Let's actually get to an answer the audience is going to like. Hap, what single mistake is the biggest one we're making?
I think I think if you just take the numbers and whatever, the most common mistake is treating people who have left heart disease with whatever pulmonary vasodilator you want to come up with.
Dr. Gomberg-Maitland?
I would say that I think the most common mistake that we make is thinking that we understand pulmonary hypertension.
I think the most common mistake is failing to make the diagnosis. These patients come in, they're told they have childhood asthma, this or that, they're obese, they're deconditioned, et cetera, and we finally make the diagnosis too late. We need to raise awareness.
I want to hear more from Dr.
You guys
Gomberg-Maitland.
all
Hold
know
on.
this.
Hang on. So Vic, that is true.
Thank you.
No, but wait, but remains true, but we have spent decades going out in the real world and trying to improve people's awareness of the disease and making the diagnosis, and at least in my mind, I don't think we've made a hell of a lot of
I
progress.
think we have. I think we made a lot of progress. Just the fact this room is full here right now, to me, is progress, that there's pulmonologists interested in care
Well,
about the
they
disease
only
state.
came to see your hair.
Marty, I want to, can you get some, can you clarify your initial points? So you,
Yeah, I think that we're all arrogant to think that we understand all of this when we can't even see the vasculature real time, right? Like in cancer, when you've shrunk the tumor, you shrunk the tumor. We have medications and patients feel better. We've done something, but then for us to be, I have old textbooks from my great-grandfather which talk about treatments that are just crazy, but at the time we're okay. So maybe, I fear that 20 years from now, they're going to be like, what the heck were they thinking?
Well, but I think part of the issue is the way, I think we've actually been led astray by the classifications of pH we actually use, okay? So
Fair.
if you look at all of that and say, well, group 1 PAH patients
So
are.
like exercise pH, you mean?
No. So group 1 PAH patients are all the same. You cannot tell me that a scleroderma PAH person and an idiopathic PAH.
But
person
we all know that. So what's the single mistake is not making the diagnosis and not getting them to an expert like many of you out there. If every patient got diagnosed and seen by an
trying to
expert like
butter
one
you
of
up.
you, then we would conquer this disease state.
Pretty good
They
argument.
need to see an expert. They
that's
need
hard
see
to
an
argue
expert.
against.
Thank you, Dave.
All right, so well, we have 9 minutes left. I want to make sure Victor gets time. So we are at equipoise here, and fortunately, we need a way to break the tie because typically this is where we sort of end, but we can't. So Vic, while you're sort of queuing up and getting ready to speak on the far side on some debrief here on the post game, I need to find a way to break the tie. So here's what I'm asking you to do. Each of you has a piece of paper in front of you. Give out some. Who has a pen? Anyone? I got pens. All right.
No, we
Back
don't,
in the days when Pharma could give us
we don't
pens,
have
could do
pens,
this.
we all have apples.
I'm going to give you, have one? All right. I'm already going to give you a pen. Hold on. All right, so here's what I'm going to ask. Clearly, you're all good at limericks, so we can't do that. So the ask
So
is-
actually, while he's doing this, I have a very funny story to tell you about him.
Okay, that's fine.
Oh, you're going to lose points.
No, he knows
He
it.
doesn't care.
So when he first left BU and moved to Atlanta,
21 years ago.
he was on a show called
Who Wants to Be a Millionaire? It's true. You can Google it and find me on
You
there.
do okay?
Wait,
I
no,
did.
hang
I got to the
on,
hot
hang
seat. I
on,
met Regis
hang
real
on.
quick because I got a task for you and I want
No,
Vic to
hang
talk.
on.
He's sucking up. He's sucking up,
he was
Dave.
on and he got
He's-
stuck
but that's
on a
really cool,
question
Dave,
about
honestly.
Southeast Asia. I was too young.
Southeast Asia. So who did he call to
you
friend
had a
for the
call.
answer?
I did not
He
call him.
called me, and I was tied
I
up, and I
did
couldn't
not
pick up
call
the
you.
phone.
I have a
Yes, you
recording
did.
of
You
it.
called me and I gave you the
Okay.
answer.
Ladies and gentlemen,
Happy called me
this
first.
is
He called me
not
first,
true.
Hap.
You can pull the recording. It's on YouTube.
No,
I did
I
not
think
call
you're
Hap
showing-
Farber.
you're
All right,
showing-
moving on.
I don't
No,
know.
He
He's got to lose points for that, Dave.
Alzheimer's
No,
must
no,
be
that's
kicking in. It did not happen. Those of you
You
on the
gotta lose
internet,
points.
pull the
Take
clip. I
points
did not
away.
call Hap
That's a
Farber.
3-point
All right.
deduction.
Shh. All right, so here's the task. We can't do limericks. Let's do haiku. I need you to write me. So haiku to review is 3 lines, 5 syllables, 7 syllables, 5 syllables. Victor, test. What topic should I have him write a haiku on? Relevant to this presentation.
Relative to this, I would say clots.
All right, so just clots in general or PE?
What did he say?
I would say
Clots.
PE.
PE, all right, so write a haiku, 5 syllables, 7 syllables, 5 syllables on the topic of pulmonary embolism. Vic, I'm going to let you present, and we're going to let the audience vote on them. Dr. Test, hand of applause for Vic Test, who's joining us now. Actually, wait, round of applause for all of our competitors, because we don't know who's going to win yet. It was fantastic. All right.
I don't even know what a haiku is.
5. If you don't know what a haiku is, you may not win. I'm going to let you. Sir. I'll help him out. Vic, you want to hop up?
You gotta help me here.
Hop up, please.
Just
sir.
like I helped you.
All right.
But I will
well,
listen.
then I'm not helping you at all. All
I
right.
will listen to you either.
So 3 lines.
Yeah?
Yep. 5 syllables in the first line, 3 syllables in the second, 5 syllables in the third. Just 3 lines. Go ahead.
Okay. Well, so while they're, trying to break this tie, which I don't remember there ever being a tie at PTI before.
Okay, I'm ready.
But,
Let him. Go ahead.
so, I mean, I'm just gonna run through a few of these things. And I want to say how much I really admire and respect these 3. That's one of the reasons I suggested them to David. But one of my favorite phrases from today was there's no data, but this is right. Okay? Like it came up yesterday in the ARDS talk, there's the right way, the wrong way, and there's the way I do it. So I think we've gotten a full dose of that today. In terms of, topics, so should intermediate risk PE undergo intrapulmonary lytics and extraction? And, of course, the data there is, shall we say, not there. But we've all seen pictures of these extraction devices pulling out these enormous clots, and the reports of, the pulmonary pressure is immediately better. And we've also seen, imaging from thrombolysis, both systemic and catheter-directed. We've been studying this for 50 years. The first trial in catheter-directed thrombolysis was in 1972. It was the UPET trial. It was a catheter-directed thrombolytic study, which showed rapid improvement at 24 hours, but no difference at 7 days compared to anticoagulation. We know that anticoagulation works. There's no question about that. The catheter-directed therapy, including ultrasound-directed therapy, have all been, been done for many, many years. Catheter-directed thrombolysis without ultrasound assistance has not dissimilar bleeding rates to standard systemic thrombolysis. Ultrasound-assisted thrombolysis, while it's been proven to be safe and effective on average in a meta-analysis study, showed only an 8 millimeter mercury improvement in mean pulmonary vascular pressure, systemic pulmonary vascular pressure, systolic, good gravy, I can't talk, and a 0.3 liters per minute per meter squared improvement in cardiac index, which is not insignificant, but at the same time, is that worth not seeing a mortality benefit? And there's no mortality benefit data for any of this, and we await those trials, hopefully with clot extraction, because we'd all like to see a better way in treating this. Also, one of the arguments for that was that if we want to prevent long-term morbidity, the PYTHOS study with its extension trial, which was a 2-year study of the largest thrombolytic trial performed yet to date, showed no difference in treatment for submassive PE with thrombolysis compared to anticoagulation in CTEPH, persistent dyspnea, and long-term RV dysfunction. So I'm going to move on from that. That was, I think
2-minute clock, if I can, Vic. Sorry, just
What?
2-minute clock on your part.
Okay. I just got excited.
I know.
Okay. So in terms of nitric oxide challenge test or vasodilator challenging testing, I just want to throw out that while it is not necessary, I agree it's not necessary for everyone, and I think the data backs that up. It is often necessary to get your patient medication. So in that sense, it probably is actually required, but it's a different spin than the medical indication. The next thing I would like to add is the 6-minute walk. So one of the things that came up, and actually, Marty, I want to congratulate you for bringing up on at least one of the topics that, this isn't available to everybody. That's true, actually, by the way, for catheter-directed thrombolysis and catheter clot extraction. But in the 6-minute walk, one of the benefits of the 6-minute walk is that it is a semi-objective way of measuring someone's exercise capacity, which is available to everyone. We don't all have submaximal cardiopulmonary exercise testing. We don't all have the ability to do shuttle walk, which is probably a better test in terms of grading someone's upper limits of exercise capacity. And so the 6-minute walk, I think, still has utilization. It's a terrible diagnostic test and shouldn't be used that way. Okay. Lastly, with the iliofemoral data, and thank you, Vic. You outlined the data pretty good, as always. I'm always nervous when I get to talk data with you because you're so much better than me. But on the other hand,
You're VT1, I'm VT2, believe me.
on the other hand, you said it well that there was in this study, which was a negative trial, The subset analysis suggested people with iliofemoral thrombosis did better. And again, with newer and better ways to approach this, I suspect that this will change, but the current data doesn't suggest that they need to be treated more aggressively unless they have significant symptoms involving the limb that's involved. Okay? I think that's pretty much what I want to say.
Thank you, Dr. Chess. Round of applause real quick for Vic. All right, lastly, we have one more task, folks. I had tried to get them to anonymize, but they've all written these about each other. So good luck trying to, despite my best efforts, I will have a difficult time to anonymize them. So I will ask the audience to grade. You can thumbs up, thumbs down, or you don't have to vote. 1 to 5 points, depending on my perspective, of the, plus that of the audience. So here's the first one. It's the only one that you may not be able to figure out who it is. A clot in the lungs, hard to breathe, and RV fails. Treat fast and quickly. It's a perfect haiku. Thumbs up, thumbs down. A clot in the lungs, hard to breathe, and RV fails. Treat fast and quickly. Lots of hands up on that one. That's at least a 4, if not a 5-pointer. Strong work. I'm not going to disclose who that was yet. Next. Good luck figuring out this one. Vic has clots, they say, but he evidently left for better pay, maybe referencing a little pharma slap, all right?
Point deduction, point deduction.
Wow, what can he say? There's actually an extra syllable in the middle line, so I have to deduct a point for that. But Vic loves clots, so they say, but he evidently left for better pay. Wow, what can he say? Thumbs up, thumbs down. Audience is split on that, so that's like a 2 or 3 pointer. Last one. Last person wrote two stanzas, so you have to judge them both. If either of them is bad, you can just torpedo it. Again, it won't be hard to figure out this one. PE sucks really bad. Let's everyone do better. It's all right. I'm not a pharmacist, so I can't read the handwriting of a doctor. Let's everyone do better. Let's conquer this, please. Technically, that is 575. The second verse is pH is tough. Only 4. Okay. Hap and Marty treat it. I don't know who wrote this one. I do better honest. All right. So average. Give me some thumbs up, thumbs down on that. Wow, the audience has turned against it. Well, on that note, I'm going to have to give 2 points to Dr. Tapson. I'm going to have to give 2 points to Dr. Farber, and our winner, ladies and gentlemen, Dr. Marty Gomberg Maitland.
Nice job. Nice job. Nice job.
Oh, I got
Wait. Hold on, man.
Oh, nice.
Okay.
Nice.
Hey, you look like Flavor Flav.
One more round of applause for all of our panelists and Dr. Tess, please. Let's do it again next year. Please drop your panels in the back. Thanks for coming. Enjoy the rest of Chess 2022, everybody.
What does it say on the thing?
Champion.
Oh.
Congratulations, champion.
Thank you.
There are very few people who have one. There's only 3 of those in existence right now.